Thank you everyone for joining today. My name is Vahed Lokant and I'm pleased to welcome you to today's webinar on RCMP Cadet Mental Health, Recent Results and Insights from the Longitudinal Study. For those of you who are long-standing attendees of our webinars, welcome back. For those of you who are new to EHN Canada, we are a leading nationwide network of treatment centres for addiction, trauma and mental health. We offer inpatient services with centres coast to coast, as well as virtual intensive outpatient options. For more information, visit ehncanada.com. Everyone is on mute and cameras are turned off for today's webinar, but we'd like you to use the Q&A box to submit your questions for our speaker throughout the session. We'll be monitoring the Q&A box and we'll have some time at the end for our speaker to address the questions you might have. We will be sending a follow-up email in the next week that will contain a link to a recording of today's session, as well as your attendance certificate that you may wish to submit for continuing education credits. To stay updated on future webinars and newsletters, we invite you to opt in to our mailing list by filling out the form that will be linked in the Q&A box as well as the chat. Allow me to introduce you to today's speaker. Dr. R. Nicholas Carlton is a professor of clinical psychology and a registered clinical psychologist in Saskatchewan. His work focuses on supporting the mental health of first responders and other public safety personnel. He has published more than 260 peer-reviewed articles and book chapters exploring the fundamental bases of anxiety and trauma-related disorders. He has completed more than 500 national and international conference presentations and has received several prestigious awards and recognitions, including induction to the Royal Society of Canada's College as a Fellow of the Canadian Academy of Health Sciences. He is the principal investigator for the RCMP Longitudinal PTSD study, the Associated Extension Study for the Saskatchewan Public Safety Personnel, and co-investigator on the Federal Internet Cognitive Behavioral Therapy Program for public safety personnel. Now, without further ado, I'll hand the stage over to Dr. Nicholas Carlton.
Thank you very, very much. That's a very kind introduction, and thank you all so much for choosing to join me today. I'm going to start with just a brief disclosure slide. I don't have any relationships with commercial interests that I'm aware of. It's not that I'm opposed to the idea entirely, it's that it simply hasn't happened. All of my research is supported either by a variety of different federal and provincial agencies, and in some cases, some of the knowledge translation efforts that we've engaged in have been supported by, very kindly and generously supported by some nonprofit agencies. I wanted to start with an overarching set of learning objectives today. So I want to begin by providing some foundational background with respect to the challenges facing all of our first responders and other public safety personnel, along with some contemporary research updates. I'd like to then shift to highlighting some of the recent research efforts associated with the RCMP so that we can better understand the barriers that a lot of them are facing to evidence-based care, and therein hopefully provide better supports for mental health. I'd also like to do some reviewing of the solutions based on the RCMP research study that we're engaged in, which is really quite tremendous. I'm very excited and feel very privileged to be part of that. And then highlight briefly some opportunities to better inform and support RCMP and other public safety personnel going forward. So that's a lot that we're going to try and tackle in 45 minutes. I'm going to give you sort of a high level of each one of these different pieces, and then I'm hoping during our Q&A session, if there's specific things you'd like us to focus on or specific areas where you'd like us to delve, that we'll be able to do that. So let's start with the definition at a high level. Public Health Agency of Canada, their journal recently released the version 3 now of the glossary of terms associated with post-traumatic stress injuries, and one of those terms is public safety personnel. So these are a host of different professionals who include our first responders as well as other groups that in many cases are working with our first responder teams or working towards public safety, but are often forgotten or they sit in other category sets. So this includes everybody from border services to your dispatchers who are first responders that are often forgotten, but when you dial 911, the first person to respond to you is actually one of those people. Correctional workers, our firefighters, our Indigenous emergency managers, our operational intelligence personnel, paramedics, and a variety of different police, as well as search and rescue. We often underestimate, I should say overestimate, the amount of these people who are actually available at any given time to support and protect all of us. So I like to just quickly highlight this because I think it's easy for many of us to forget that we're talking about a relatively small and unfortunately right now shrinking number of people who protect and serve all of our interests. So for every 1,500 Canadians, only 13 of them are public safety personnel. 4 of them are police across 3 different levels of policing. 1 of them is a career firefighter. 5 of them are volunteer firefighters. And that is, in fact, true. Most of the firefighting in this country is actually done by volunteers. Our paramedics, we have 1. We have 1 correctional worker, and we have a little less than 1 border services worker. And there are far fewer than 1 PSP for every 1,500 Canadians from the other categories. So this is part of why I'm very impassioned to try and make sure that we're protecting, to the best of our ability, all of their interests, because there's so few of them to protect and serve so many of us. When we take a look at the current state of the challenge that they're all facing, we've got data that we had collected in 2017 and was published in 2018 that really showcases the challenges that they were facing relative to the general population. At that time, it was about 1 in 10 members of the general population who met diagnostic criteria for 1 or more mental health disorders. But for our currently serving public safety personnel at the time, it was nearly 1 in 2. We've since done several different kinds of updates here, and as part of that updating, there's also been an update to the general population, and we've seen data collected in 2022 and 2023 that has really shown an increase across the board in the challenges, mental health challenges facing our general public. That's thanks to some StatsCan data that was recently released. I put a little asterisk there because I guess we're going to have to wait and see what happens. A lot of the increase there is probably related to a variety of different COVID-related stressors and challenges that everybody has been facing, along with some of the other socioeconomic challenges lately. So I'm not sure if it will hold at that increased level, but even at that increased level, the 2017 numbers would still showcase that our public safety personnel are facing a huge set of challenges. We were also able to collect new data, thanks to the National Police Federation, about RCMP so that we could update the RCMP specific numbers. And we were able to collect that data in 2023. And as you can see, from 2017 to 2023, they went from about 50% screening positive for 1 or more mental health disorders to 65% screening positive for 1 or more mental health disorders. And that's of our currently serving RCMP officers. This doesn't include the approximately 2,000 members who are off on leave for a variety of things, including different kinds of mental health challenges. So we're talking about a very large set of problems and a very large set of injuries that need to be addressed. We see similar patterns with respect to difficulties with suicidal ideation, planning, and attempts, wherein all of our public safety personnel are reporting levels that are higher than we would expect for the general population. And we are also seeing challenges having increased depending on which data sets you want to look at for our general public. But really, the big jumps that we're seeing were also associated with our RCMP from 2017 to 2023. One of the challenges with collecting suicidal behavior data, like this, is that really it's based on self-report. And so, of course, anybody who died by suicide, those numbers are not actually captured in the data set that we have here. And it's very difficult to get a solid, good handle on the number of our public safety personnel who are dying by suicide in any given year or over the course of 2-3 decades. In part because of reporting difficulties and in part because there's a lot of stigma and bias that goes along with the mental health challenges that they're facing. So we have a significant opportunity there to do better for all of them. We also see similar challenges with respect to chronic pain. And the reason that I'm flagging that for all of our clinicians who may be joining us today is because, as I'm guessing you know, chronic pain and mental health conditions, particularly post-traumatic stress disorder, are highly comorbid conditions. And they can be mutually reinforcing conditions, which is a huge problem that we're facing as well. So for our public safety personnel, you're seeing some pretty significant challenges with a variety of different kinds of chronic pain. Those chronic pain injuries, from what we've seen so far, appear to be very much related to service. So about 5 or 6 years ago, when we began doing some of, maybe it was 7 years ago now, we began doing some of this work. One of the comments that had been raised with us was, well, but these are people who are often engaged in high-risk activities. How do you know that those high-risk activities are not their entertainment activities instead of their vocational activities? The results that we've got suggest that that's not the case. The vast majority of the chronic pain, the public safety personnel are able to identify as having occurred as a function of an injury that they experienced while they were on duty. And so that's a big challenge for all of us. In many ways, I don't think that should surprise any of us, though. So if you can imagine somebody trying to rescue someone from a car accident, you might not be able to engage in the safest way to do lifting or maneuvering in the middle of an emergency situation. And our public safety personnel really prioritize the health and well-being of the community members that they serve. So in doing that, it does increase their risk for physical injuries alongside their increased risk for psychological injuries. So I would imagine that we would have seen similar increases for all of our public safety personnel with respect to their mental health challenges, their suicidal ideation, planning, and attempts, and their chronic pain challenges to what we saw for our RCMP over the last 5 years, largely because they've been experiencing the same challenges everybody else has, but they've had to stay out on the front line. They've also had compounding challenges that have been impacting them, such as reductions in available service personnel, increased demands for services, increased demands for different types of services. In addition to those areas, we often get asked, well, let's talk a little bit about those exposures to potentially psychologically traumatic events. So many of you may recognize these. These are the LEC5 events from the National Center for PTSD down in the United States, and they're very much consistent with Criterion A events for post-traumatic stress disorder in the DSM-5. One of the things that I think we often forget is really the order of magnitude of exposures that our public safety personnel are facing. So in the general population, based on the best available data we have right now, somebody like myself is probably going to be exposed to 5 or fewer potentially psychologically traumatic events in my entire lifetime. And many of us will be exposed to no potentially psychologically traumatic events in our lifetime. In contrast, our serving public safety personnel are going to be exposed to hundreds, thousands, tens of thousands of these events, largely because what we are asking them to do is intervene for the rest of us every single time one of us experiences those kinds of events. So we're deploying them repeatedly to engage with these kinds of events. And when you take a look at the data that we have here, the reason that we ran this particular set of analysis with a very large sample that we had was there was a notion about 50, 60, 70 years ago that these events, at least some of them, may be causing problems for our public safety personnel mental health. But what we need to do is identify the subset of the really bad events. So what events are the really bad ones? And we'll call those critical incidents. And those critical incidents will be the ones that we use as markers for deploying additional resources. Well, there's a bit of a challenge. There's multiple challenges with that, but there's at least a few challenges that should be highlighted with that. First and foremost, the data that we have so far suggests that almost all of these are associated with an increased risk for post-traumatic stress disorder, and almost all of these are associated with an increased risk for a variety of different other mental health challenges. And the ones that are not statistically significantly associated with that increased risk, actually, we believe the reason for the lack of the association is because there was a ceiling effect. They had received so many exposures to these that it didn't produce a statistically significant relationship because they were all associated to all of these kinds of challenges. So what these results suggest is that rather than creating a set of specific kinds of events, that for these events, we're going to deploy additional resources. Instead, what we need to do is allow the individual themselves to identify that an event has been problematic and then reach out for additional resources that should be available for them. So I would encourage you to keep this in mind so that we can help sort of push back against this 50, 60, 70-year-old narrative that some of these are the really bad ones and do deserve medical attention or healthcare attention, but the rest of them are not all that bad and they would be associated with things like malingering. In addition to those potentially psychologically traumatic events, though, we've also seen a huge number of challenges with other things being associated with a variety of mental health disorders. So in one of the studies that we were able to run, and it was a cross-sectional study, so you should take that with that bit of a grain of salt because we, of course, need longitudinal data for this. What we were able to demonstrate was that about half of the variants might have been associated with those potentially psychologically traumatic events, but another half was actually associated with other occupational stressors. So I can't stop the car accidents from occurring. Unfortunately, I don't think most of us can. On what we can, though, impact are these other occupational variables. And so if any of these we had hypothesized are associated with mental health, these are levers we can engage with. We can have discussions about doing other things. And as it turned out, what we found from this data set was that all of these stressors were associated with an increased risk for difficulties with PTSD or any other mental health disorder. So this raises some really important challenges for all of us. First of all, most of these are actually resourcing related. We could choose to help their mental health by changing the resource matrix that we've got, by investing in our public safety personnel and reducing some of these organizational and operational stressors. I think this is also important for our clinicians to keep in mind, largely because what it means is we want to make sure that we're not getting exclusively focused on a potentially psychologically traumatic event or even an accumulation of those events to the exclusion of recognizing that there are a host of other stressors that are impacting their mental health, and those other stressors may also need to be addressed in order to provide supports. We also were able to do some research assessing training because as we've learned more and more about the challenges that all of these public safety personnel are facing, a lot of people stepped up and said, well, we've got to be able to do something about this. Can we provide different kinds of training? Can we provide some kind of early intervention that can be helpful? And so we were able to analyze and assess data and try and answer some of those questions. So first of all, one of the things that we were able to identify is that the training doesn't appear to have a major impact on whether they're going to access different kinds of evidence-based care. So between any training and no training, we didn't see huge changes across the board in whether that training makes people more likely to access care. But an incidental finding that I think is really important was that we were also able to identify that unfortunately our healthcare professionals and the PSP leaders, these aren't the first places that our public safety personnel are turning for help. More often than not, where they're turning for their initial points of help are their spouses and their friends. That should, in theory, make a lot of sense to all of us because that's where most of us turn first, right? If we're having trouble, we're more likely to turn to a spouse or a friend first and foremost, rather than accessing any kind of formal support. So there's a couple of different elements of that tendency on all of our behalves. The first element is that means it's probably going to take a lot of effort in some cases for us to turn our attention to professional supports. The other thing that we need to identify there, though, is that the spouses and the friends are taking a lot of that burden on. So they themselves may need psychoeducation and supports in order to help our public safety personnel. And in addition to that, they may need their own resources to help manage the stress that they are experiencing. And so there's a variety of different interventions and support teams that have come out to try and manage that special case for our spouses and friends of public safety personnel. There's also a lot of problems with stigma, and we saw this in 2017, and we have only heard that this has either sustained or in some cases gotten worse, ironically, since that data collection. There's a widespread belief that coworkers who are taking time to address their mental health needs may be abusing the system. There's also a lot of reporting that understaffing may be increasing scrutiny of injured PSP who are left to then manage the additional burden. So when we take somebody off the front line, that necessarily increases the stress on everybody who remains on the front line, even if we believe that person should be taken off the front line. And as you do that more and more, the burden of proof that the next person should be taken off of the front line necessarily starts to increase in a biased sort of way because we become more stressed about the team that we have left. A lot of this, again, though, is related to fiscal constraints that can be creating or at least potentiating system-level stigma and concerns for any leaves of absence. What that means for all of us is we need to be prepared to help our public safety personnel in many ways to defend against that narrative for those who are choosing to reach out to gain access to mental health care, because that's exactly what we want. And what we do know already is, based on what we're seeing, it's not likely that they're going to need mental health care once in their life. It's in fact more likely that they're going to need mental health care multiple times in their life as a function of what we're asking them to do. And so that means at this system level, we need to begin building protections and strategies and possibly even policies or legislation to make sure that they have those capacities built in. And if we're going to do that, then we need to also protect the system in general, which means higher levels of investment and more personnel so that we can look after their mental health in the long term. Since 2017, we've seen a whole pile of additional stressors that have impacted them. The stigma, in many ways, like I had mentioned, has gotten worse, but there's also been a host of media attention. Unfortunately, some of it positive, but a lot of it actually quite negative with respect to our police, how our other public safety personnel are interacting with the community, and demands that they continue to do more and more with less and less. But they have also been impacted by COVID-19 in a variety of ways. And we're hearing widespread indication of substantial burnout as a function of the additional stressors being placed upon them. That's also, though, impacting recruitment and retention across the board for our public safety personnel. So if you imagine, if you're a young person looking at different career options, if you're watching how we are collectively treating and interacting with our public safety personnel right now, it can be very difficult in many cases then to support recruitment. And as the challenges within the system get larger, it can be very difficult to support retention. And that's what we're hearing from a variety of different sources right now. We also run into an additional level challenge that since 2017, there has been a massive proliferation of programming to try and address the mental health challenges that are facing our public safety personnel. And you can see a lot of that here on our PSP mentalhealth.ca project website. There's more than 300 of these different programs being proffered in a variety of different ways, and they're available irrespective of the evidence base. That's a really important clause because despite there being a massive number of choices and options that are available, the ones that are engaging in evidence-based practices, particularly when we're talking about training or early interventions that are not predicated on our clinical practices or on things that we already know work, the number of evidence-based content pieces that we've got there are actually vanishingly small compared to the number of options that are available. We're also running into challenges about culturally informed clinicians, and we don't have a university accredited or tailored PSP training program specifically for clinicians in the same way, for example, that we would do if you wanted to declare a specialty in child and adolescent or a specialty in psychosis or those kinds of psychiatric illnesses. We've also got no research evidence at this point to inform us on how best to build culturally informed clinicians who are going to be not only trauma informed, but psychologically safe for their patients and themselves. So we've got a lot of work left to do in this space collectively. That doesn't mean we shouldn't do anything until the research comes out. It just means we have a long way to go compared to where we are with a variety of our other pieces of programming. So I encourage you all to engage with that when you can. But one of the narratives that we hear all too often, and that I've heard many, many times from our public safety personnel leaders, is I finally got this person, whomever it was off the front line, to go and access mental health care. And when they went and saw the clinician asked, as I'm sure many of us do, what are you here to see today, or what are you here to see me for today? And when the experience or the challenge was described, the clinician ended up needing support from the public safety person who was there to essentially receive support themselves. That's a huge challenge that we're all going to have to tackle together over the next 10 to 20 years as fast as we can so that we can support these people. We also know that any kind of early intervention or mental health training program that we build in, so far, those single session resiliency training programs and interventions are providing pretty consistent results when we do have research evidence. And that is that they're perceived as helpful for increasing awareness and understanding and communication and correcting some mental health related myths. But the actual results are actually producing small temporary changes in mental health symptoms, resilience, work engagement, knowledge, and stigma. This, though, should not come as a surprise. That's largely because any individual single session training program on any piece of content is really only going to be able to have so large an impact on people going forward. We can only do so much in an hour, right? If I train you on one particular skill, there's only so much I can do in that hour. And if you're not going to practice it and have ongoing feedback to continuously improve the skill, you're going to have a lot of difficulty using it at an expert level going forward. We've also seen some meta-analyses across these different kinds of programs that have really supported the same kinds of challenges and have really underscored the idea that what we need are broad system-level program evaluation opportunities and engagements so that we can better understand how to iteratively improve programming and develop new programming to support mental health. And even when training works, the big challenge is that skill decay is real, and skills grow and decay based on intentional practice and ongoing use. It's why we have continuing education requirements for so many of our professions. all of this really speaks to the same kinds of challenges that we're not going to be able to have a one and done to intervene to protect our public safety personnel mental health on an ongoing basis. We're going to have to tackle this as a systems level, ongoing lifetime set of challenges, and then build increasingly improved systems to protect all of those who are protecting and serving us. We do have some evidence-informed tools now that I would encourage you to use. I'd like to make sure people can take some practical stuff. On the cipcert.ca website, for example, there's a host of screening tools many of you are probably familiar with, along with tailored feedback that is specifically normed for our public safety personnel. The entire thing is anonymous, but you can go online, for example, and complete a GAD-7 and get immediate feedback on where your results are relative to the normative population and then relative to a specific public safety personnel group if you're so inclined. The entire thing is anonymous and entirely free for people to use as often as they would like. There's a host of other evidence-informed tools that I would encourage you to take a look at if you're so inclined. A Sleep 101 toolkit, help for finding clinicians, a suicide fact sheet, and a way to evaluate the many, many different wellness programs and services that are being made available. We've also got the new glossary, version 3, that is currently available thanks to support from Public Health Agency of Canada and HPCDP. I encourage you to take a look at this because a lot of the language that we're using, we found as early as 5 or 6 years ago, we weren't all using language in the same way that we thought. So there's a variety of terms associated with post-traumatic stress or any of our trauma-exposed professionals that we aren't using in the same way. And so this is a collective effort from coast to coast to coast from a variety of groups to try and at least get everybody on the same page. So that if I'm using a word, we're both sharing the understanding of what that word means. And if we have a conflict about what that word means, we both identify that that word might mean 2 or 3 different things depending on who we're talking to. So we're sincerely hoping that that's a useful tool for you going forward. There's also a bunch of webinars and town halls that are available across a variety of different groups that are very specific to this area if you're interested. And of course, standard resources across the board that I'm imagining many of you are familiar with, but I would encourage you to take a look here. A lot of the evidence-based resources are really, they're readily available, and I think they're a fantastic place for us to get started. So a lot of this coincides with the RCMP study. And the RCMP study itself began 2017, around the same time that we began doing this data collection. And the RCMP had identified that there were a host of challenges facing their members. And they said, you know what, we really want to build an applied research solution. We want to do something that participating in the study is going to help people, not only in the future, but the actual participants themselves. We want to build an entire set of systems and better understand how we can protect and serve all of those who are protecting and serving. So I was very privileged to be part of this. It's an initiative that's being done in partnership with the University of Regina. To our knowledge, if you look at the scale, breadth, and depth of the study, we think it's a global first to try and really tackle some of these challenges. There's certainly lots of studies that are being done in different ways with different elements. We think this is really a laudable, massive step forward that's been made by the RCMP. For those of you that are interested in methods, it's a prospective longitudinal applied multimodal study. The short version of that is that we are measuring people over a long period of time using a variety of different tools in order to comprehensively understand where their mental health is at the beginning of their training, throughout their training, after they're deployed from training, so that we can get a handle on the different factors and variables that are interacting to create risk and resilience. And that we're hoping is going to lead to a variety of different solutions to help better mitigate the challenges not only the RCMP are facing, but by extension, everybody else. Just a quick shout out here. I get to do a lot of these presentations, and I'm very privileged to do that, but this is made possible by a massive team of researchers and clinicians from a variety of different institutions who make all of this possible. So I'd like to just flag that you don't get to do this without tremendous support, but I'm very grateful for. So the RCMP study itself was designed with one overarching, simple to say, hard to do goal. We want to reduce the incidence and the prevalence of mental health injuries, specifically post-traumatic stress injuries, among serving RCMP. So to do that, we built a system that would allow us to engage in ongoing mental health monitoring. They wanted to have a conversation about, is it possible to get away from solely and exclusively depending on self-report? And so we said we can try. There's some evidence back then that this might be a possibility. So we have biometric monitoring. They also wanted proactive mental health activities and evidence-informed training so that we could try and protect people going forward. They wanted a way to gain earlier access to mental health care. and to do a better job of balancing and realistically making attainable the balance between individual and organizational responsibilities for mental health. I really think this was prescient of the RCMP and the leadership of the day, and we've only seen that supported since. When we talk about mental health, unfortunately, all too often, I think we end up in a very polarized conversation, not intentionally, as to who's actually responsible. Is it the person who's responsible? Is it the organization? And I think the reality is we have to accept for our public safety personnel that it's going to be a shared responsibility, not only between the individual and their organization, but with all of us as members of their community. So at a very high level, I'll give you some study design points. All of the participants in the RCMP study start with a full psychological assessment. They have a massive amount of surveys, a clinical interview that they participate in. It's a very large comprehensive assessment that has been brokered off of some of the best practices done from coast to coast to coast in a variety of mental health care facilities. So we do this full mental health assessment at the onset of their training, and then we do it again before their deployment. And then we repeat it on the anniversary of their deployment for 5 years thereafter. In addition, we have a monthly assessment that screens them for major mental health disorders, a daily survey, and a daily seismocardiogram that they participate in so that we can see if we can use and identify biometric tools to help us with mental health injuries. So we've got 2 teams for this. We have a team in the RCMP who received the standard training that Depot had, and then we've got an augmented training team that follows thereafter, and that's the team we're working with right now. We get questions about the daily assessments, the monthlies, and the annuals. So the daily assessments are ultra brief. They assess 13 factors based on a variety of different cohesive and interlocking models, and it takes about 60 seconds for them to complete. We all know from a bunch of other mental health research that taking even 60 seconds to reflect on your last 24 hours and then to chart and monitor that, it's good for our mental health. This gives the RCMP a dedicated system that allows the support for that kind of self-monitoring and that kind of self-reflection. The monthly assessments have 20 clinically validated measures of mental health that I'm guessing many of you would be familiar with. It takes them about 20 minutes to complete, and they get immediate feedback and live reports so they can actually track their own symptoms over time and identify trends and take control or agency of their own mental health. That initial full survey that I talked about that we repeat on the before they're deployed and on their anniversary, that one takes about 75 minutes to complete. But they also get immediate feedback and live reports, and it provides a tremendous amount of information for them. And in both the monthlies and the large-scale full surveys, it flags for them when they might meet criteria for one or more mental health disorders or when there's been an increase in their mental health challenges. So all of that reporting information gets funneled into individually tailored dashboards so that they can look for different kinds of patterns in their mental health, which gives them agency. So some patterns are easy to see. This is a real example data from a real participant. You can see that there's an easy pattern there. There's a weekend, there's a weekend, there's a weekend, there's a weekend. But they can identify more complicated patterns, like every second week, I'm having a problem on a Wednesday. What's going on that Wednesday? And identifying those patterns can help clinicians also to build more tailored, nuanced interventions because they can export all of this material and take it to a clinician of their choosing. And that's what we believe is actually happening in several cases. So, for example, this is, again, a real participant who saw a jump in their PHQ-9 MDD scores from June to July, and that was flagged for them. And then you see a pretty rapid fall in those symptoms. They never met clinical cutoff, though, and that's, I think, a good thing. Because the data that we have suggests that actually they went and accessed evidence-based care and that evidence-based care worked effectively. So instead of waiting until they exceeded a clinical cutoff, instead of waiting until they had compounding problems and allowing an injury, a psychological injury to fester for months or years on end, because they were able to identify that an injury had occurred, they gained access to care quickly, and they sort of treated it like a physical injury. We wouldn't let a cut on our leg fester forever. We shouldn't let a psychological injury fester either. And this is one of the more exciting things that we're seeing right now that I'm hoping we're going to be able to use as a base tool to support all of our public safety personnel. That regular self-monitoring and periodic health screening appears broadly beneficial, and I'll show you those results in just a second. But that's not news, right? That's consistent with safeguarding models. It's consistent with a lot of other mental health research. It's consistent with the challenges, those of you who are involved in mental health research, that you face if you're running an RCT or if you're running a clinical trial. monitoring and self-reflection and that metacognition is good for our mental health. And so it's the fact that we're seeing these kinds of gains is actually really consistent with a bunch of other work that we've already done. Those independent electronic health records get stored safely within the university system, but the user can export them and continue to use them on an ongoing basis when they're working with their own clinicians. It also does potentiate something that we're having some pretty exciting conversations about right now, and that is you could take that aggregated data and create a mental health dashboard. So imagine if you're a public safety leader and you actually now have the opportunity to, while maintaining your people's anonymity, so that you don't know who is communicating specifically what, you could actually see the organization itself ebb and flow with respect to mental health in near real time. Well, this gives them a tremendous set of opportunities to actually intervene and do what I know they want to do, which is a better job of protecting their people. But demanding that they do that without giving them a tool that allows them to engage with it, that becomes a real big challenge. So this is part of what we mean when we say that we're trying to do a better job of providing tools and balancing individual and organizational responsibilities. The seismocardiograph data that we're collecting right now is working. So we're very excited about this. We do think that we're getting quite close to a biometric tool that might identify a mental health injury. The team we're working with on this is the LLA Recordis device team, and they've been fantastic, but they were originally focusing on trying to identify things like heart attacks 2-3 weeks before they occurred, and they were getting very, very close. And the seismocardiogram requires about 60 seconds for the recording during the day, and then we provide our users with a dashboard. It's a very heart health heavy dashboard because we used the dashboard that existed. But as you can see, this is some data for me. I wish I was still 45, but as you can see, the tool really can identify changes in your heart health and your heart age over time. So we're very excited about the pending data and results here, but we have a little ways to go yet before those will be available for prime time. The intervention we often get asked about. The intervention in and of itself, when we started working with the RCMP, we started with the notion we want to focus very specifically on things that we already know work. So we looked at treatments that worked. And one of the most robustly supported treatments in the world is the Unified Protocol for the Transdiagnostic Treatment of Emotional Disorders. So we began working with Dr. Shannon Sauer-Zavala and a team from the RCMP in order to modify a treatment that was skills-based that we know works and convert that into a training program that could be integrated into the cadet training program and provided as an ongoing support tool for our RCMP. So we renamed that after the conversion, the Emotional Resilience Skills Training Program. And we had already some preliminary support that this is beneficial from some work done out of the States, but we're very excited about what's coming next. We launched that programming in June of 2022, and it's 13 weekly 1-hour sessions with assigned homework and testing that's fully integrated through the CTP. That said, success still requires practice, and that's part of the research that we're in the process of working on with the RCMP right now. If you're interested in accessing a lot of these results that I'm about to show you, you can do so by clicking on the research link at rcmpstudy.ca, where you're going to have access to being able to download the full research article if you'd like, thanks to some of our supporters like Medivy Health Foundation. We've been able to pay those open access fees for you so that you can access them. But there's also general audience summaries and one-page infographics that provide the essentially page-by-page, research article by research article results. The RCMP study really, I think, pushes back against some 100-plus-year-old arguments that, for example, if we were just hiring the right people, we wouldn't see mental health challenges. Well, this is an important narrative that we all have to push back against because we've seen this since World War I. And in our military, we've done a good job, I think, of helping to stamp out these kinds of very outdated notions. These are real quotes or translated paraphrases for real notes about what we used to think about mental health. Here's what we know, though, about mental health now, because a lot of those quotes were propagated into notions for the RCMP. Like, if we just hired mentally healthier people to begin with, then we wouldn't have mental health challenges among serving RCMP. Well, the data so far out of the RCMP study actually doesn't support that. The results so far actually suggest that we are hiring and turning into cadets and then RCMP some of the most mentally healthy people that we have in our Canadian population. So we don't have healthier people to go and collect to turn into RCMP in the first place. We also know that our cadets themselves are reporting more potentially psychologically traumatic event exposures prior to choosing to serve than we would expect for the general population. So this may increase in one way some of the risk that they may have, but this may also be a motivating factor for why they're choosing to serve. They want to make the world a better place in part because of their own experiences. This, though, also interacts very importantly with the data that I just showed you. So if they're seeing more potentially psychologically traumatic events than the general population, but their mental health is better than the general population, that sort of alludes to the idea that our RCMP are starting more resilient and with better coping skills than we would expect. And in fact, when we go a deeper dive into this, we've been able to look at a lot of the psychological variables that we know from other research are associated with a variety of different mental health disorders. And as it turns out, when you look at these, resiliency, which we can have an entire discussion about that word and our understanding of that word, but their resiliency scores are higher. And the risk variables that we've seen associated with mental health challenges elsewhere are all lower than the general population. So this further supports the narrative that, in fact, our RCMP cadets are starting with better mental health than the general population and more resilient than the general population. We also see that their personality scores are consistent with what we would like to see for contemporary police. They're more honest and extroverted and humble and agreeable and fair and social and gentle and patient and altruistic than the general population. They're also less emotional and less fearful than the general population. So we're really seeing some opportunities there that underscore what we're hiring in to become RCMP really are some of the best people that we would like to see fitting that. The daily monitoring and the monthly monitoring system that we've built, we're also very excited about this because, and this is being released on the website right now, and we're seeing reinforcing data that further supports this contention. As few as 2 of those minutes a week is associated with better mental health. As few as 1 monthly survey every 2 to 3 months is associated with better mental health. More is better. But what we're seeing is that the self-monitoring really is doing exactly what we would expect. And that is, it's not just identifying early opportunities to reach out for help. The participation and that metacognitive awareness is literally helping to protect their mental health going forward. And so we're very excited about those results. We've also seen things like physical activity and regular exercise doing, again, exactly what you would expect from the contemporary literature, which is exercise is good for you. And our RCMP cadets start with little to no chronic pain for the vast majority of them. We've been talking about whether this is a transferable and scalable solution. And I think one of the highlight pieces that I'll flag for you is that at this point, we have no reason to believe that any of our other public safety personnel are dramatically different when they start their careers from our RCMP. So if we're seeing that our RCMP and by extension, arguably our other public safety personnel are starting healthy and resilient with terrific capacity, and then we are contrasting that with what we see among our serving members, that huge proportions of them screen positive for mental health disorders. This really does move the onus for their mental health challenges onto the rest of us, because it is their service that's causing these challenges. So we're trying to expand the RCMP tools right now to a broader set of public safety personnel. And that's what we were able to do thanks to some funding from CIHR. We were able to roll out the same tools and training to currently serving municipal police officers, firefighters, paramedics, and comms officers. We were able to do this as part of a 3-year study in collaboration with several different PSP agencies who were incredibly generous with their time and their resources and their commitments. There's actually a substantial commitment that you're talking about when we're talking about engaging the RCMP study tools and training. So those results that we're seeing are impressive and exciting, and they have all kinds of opportunities that we want to discuss and focus on for everybody going forward. But it's not a one and done solution, and that's something that we're highlighting. Part of what we think is making that system work for the RCMP is that it is an engaged system. It's a thorough system. It's not a 1-hour solution that we're hoping is going to last. It's actually a fairly intensive set of interventions that you're doing at a systems and organizational level to protect people. We saw a wide variety of participation models when we extended the RCMP study as part of that trial. Our paramedics struggled the most in order to participate and receive the kinds of organizational supports they needed. And that was reflected in them having slightly lower gains than, for example, our firefighters who had much higher gains. Part of this is because these are still skills. Just like many of you know, mental health advancement really does come from skills and practice. But if you want to do that, you need structural organizational supports as well. So the results are currently under peer review, and we're hoping they're going to be out soon so that we can share them broadly with all of you. But the initial results were already better than we had expected for all of our groups, particularly for our firefighters. Again, our paramedics had more challenges, and their comments were that they needed more structural organizational support in order to engage with the programming. The RCMP mental health monitoring tools, though, really, they've been successfully adapted, and the results that we've seen from those for a variety of different serving public safety personnel are also under peer review, but we saw the same thing. That self-monitoring system in and of itself appears to be protective and beneficial for mental health. The IRST itself, we had adapted, and that again appears to be successful as a set of tools, but practicing those evidence-based skills appears crucial. Again, that's not a surprise, but it is something that we're all going to have to collectively work towards. If we want tools and solutions that we have that we know work to actually work meaningfully for public safety personnel who are serving, we're going to need to make some broader changes to how we conceptualize mental health. So I've got just a few high-level recommendations based on the results so far, and then I'm hoping we still have good time for questions. First and foremost, evidence really matters. I assume I'm probably preaching to the proverbial choir when I say this, but the amount of myths that are out there, and some of these are very problematic myths when it comes to PSP mental health, are quite astounding. And as research data is collected and produced with longitudinal evidence from the RCMP study and cross-sectional evidence from a variety of other pieces of research that we've had the privilege of doing, really it is mounting that our public safety personnel are having challenges as a function of their service. Not just the PPTE that they're exposed to, but also the other occupational stressors. And so collectively, we need to do more and we need to do a better job because we're seeing, since COVID-19, increased problems with recruitment and retention. So we've got to do better because we all depend on these people for our own safety. I also encourage everybody to stay informed. The research results are coming out themselves actually quite rapidly now. And so myself and my colleagues across the country who work in these areas, we're eager to share the research with you. But some of that also is going to require that you're pulling that research down from various sources yourselves. Subject matter expertise in the area is also crucial. This is something that we've heard for many, many years now. The more informed the clinician teams are, the more informed the clinical practices are about the specific, unique needs of public safety personnel as a group, and then the sector-specific needs, the better off we are at providing services to support them. And that leads me to the next one, which is please carefully consider tailored clinical assessments, treatments, and recommendations. We need to keep in mind that we have things that we know work, and we might need to deploy those things multiple times because, unlike myself, for example, if I end up experiencing a trauma and I need one of the evidence-based treatments for PTSD, we're not assuming that you're sending me back out to be re-exposed to new traumas tomorrow or during my treatment. But for most of our public safety personnel, that is the latent assumption that we're sending them back out again. So we need to keep that in mind when we're working with them. We also need to build, I believe, and support cradle-to-grave evidence-based systems. If they're choosing to serve all of us in these capacities, we need to start by protecting them right at the beginning of their career, all throughout their career, and after they're retired. In many ways, we have models for this with respect to things like our military and our veteran communities, and I'm hoping we can build on those. Because solutions for our public safety personnel, while we can inform them from terrific evidence and research that's being built by a variety of different groups all across Canada and internationally, we really need individual, family, organizational, and systemic changes if we're going to meaningfully bend those curves and help protect their mental health. Those long-term strategies really require all of us, everybody who's choosing to attend today and all of us, the organizations that are involved, to collectively push for continuously improved ongoing evidence-based assessments, training, support, and interventions. And it's going to require that ongoing effort from all of us for probably an entire generation to really see the changes that we'd all like for everybody who's choosing to serve. So with that, I hope you found this interesting. Thank you so much for choosing to join me today. And I'm very excited about the work that we're doing and eager to answer questions and have a discussion, assuming that we're still good for time. So thank you all very much again.
Thank you so much for that informative presentation. Really appreciated that. Just a note to the audience, if you have questions, feel free to type them into the Q&A box and we will try and get to them over the next few minutes. A reminder to stay updated on our future webinars and newsletters. Feel free to opt into our mailing list. There is a link that's been pasted into the chat and the Q&A box. So make sure you sign up for that. You'll get a recording of today's session as well as an attendance certificate in the coming weeks. So if you have any questions, feel free to type them in. Dr. Carlton, I'll go with a question that someone had sent earlier. You had mentioned about how we don't have as many culturally informed clinicians as we might like. What advice would you have for someone graduating from a clinical psychology program who wants to support public safety personnel? How can they support in the best way possible?
That's a fabulous question. Thank you. I guess there's a variety of different trauma-informed training programs that are available from several different institutions all across the country, several organizations offering them. I would start there to make sure that you get, first and foremost, a handle on understanding what trauma looks like and what trauma-informed practice and care looks like. I would also encourage people who are interested, if you're just starting to read a lot of the contemporary literature and get a handle on the challenges that public safety personnel are facing, looking at the numbers that we've got, presentations like this that do quick highlights so that you can understand the kinds of challenges that they're facing. It's very different from all of the rest of us. So and I have the privilege to know a great many public safety personnel, and I have to work with them in a variety of capacities. They're never, just by example, they're never really off duty. So if I'm sitting with one of my police officer friends and we're out for dinner somewhere, if something goes wrong, it's not like many of the other professions. They don't go, you know what, I'm off duty right now, nothing's going to happen. They're always just a little bit on duty. So that's just one of the many unique challenges relative to the rest of us, because there isn't somewhere that they go where they're no longer going to be a police officer, a paramedic, a firefighter, a correctional worker, and help people. So I would start with that. Then I would also reach out and get mentorship. There are some very experienced clinicians out there who are very comfortable working with and very successful working with public safety personnel. A lot of them work with EHM. I would see if you can get mentorship and specific practica and residencies that focus on this, so that you can develop the kinds of skills and tools that you're going to need in order to serve these populations, and then spend time with them. That's the last piece that I would do. The more that you spend time with them and really understand the challenges that they're facing, the more you engage with them. If you have a chance, go to a police station, go to a prison, go to a fire hall, work with one of the paramedic units, identify these things, go and do an overnight if you get a chance at one of the comm centers. These are tremendous experiences that can really help you better understand and then support public safety personnel.
Thank you. That's excellent advice. Perhaps we can close off today's session with a final question. Was there anything unexpected, or what would be the most surprising finding from the study you just presented today?
I guess there were lots of different unexpected things. The personality profiles were a pleasant surprise that the results were that dramatic, that our police, that people that are choosing to serve have the profiles that we would hope for our contemporary policing agents. They are the kinds of people that we want to become police officers. And I think that's one really important sort of broad finding. I guess the other important clinical finding that maybe was a bit of a surprise was just how much of an impact that ongoing monitoring really does have on their mental health. So if you take it, those of you that are interested, if you want to download the details of the publication, I would encourage you to do it. There's a tremendous amount of stats in there and some good effect size nuance that we don't usually cover in our presentation. But things that we know work for our public safety personnel, that we work for our general population, do work for our public safety personnel. Our challenge is making sure that the tools are given to them and that they're supported in using those tools. And so many of the clinicians that are joining us today, in many cases, you know exactly what to do. It's the challenge for us is making sure that we're supporting them doing it on an ongoing basis. And that can be very different than what a lot of us are used to. We're not repairing an injury and then we're good, hopefully, for going forward. We're supporting someone's health on an ongoing basis in the same way that we'd support their physical health. The results showing that that's working as well as it is we were very pleasantly surprised to see that because it's an attainable set of tools.
And in some ways, it's a joint responsibility we have to present these tools and ensure that public safety personnel are aware of them and reminded to use them, in terms of, us as clinicians, case managers, peers, general public with public safety personnel folk in our lives. It's really important that we can support the best way we can. So once again, I thank everyone for attending today's webinar, and thank you, Dr. Carlton, for your presentation. As a reminder, everyone's going to get a recording of this session, and feel free to opt into the mailing list so you can hear more about webinars like this one. Thank you.